Welcome to the Executive Innovation Show podcast, where we bring you real executive conversations with industry game changers and thought leaders. We ask the questions you're thinking, what you're scared to ask, and we make your brain hurt afterward. With your host, Carrie Chitsey Wells, co-founder and CEO of One Touch Video Chat, live video interviews, and the nonprofit Humans Helping Humans.
Hello, everybody, and thank you for joining today's podcast. We are going to talk about, can video-based outpatient substance abuse treatment programs work? We have an awesome guest with us today, and of course, I'm here with my co-host today, Daniel Miller, COO from Humans Helping Humans. Daniel, how are you this afternoon?
Oh, I'm doing really great. Excited to have this conversation.
Well, we have our caffeine, and we have awesome Peter Loeb with us. He is the co-founder and CEO of Lionrock Recovery. He comes from two decades in Silicon Valley. He's a Harvard MBA. He'll probably kill me for saying that. And he got into the substance abuse treatment after seeing family and friends struggle with substance abuse disorders. Peter, welcome to the show.
Thank you, Carrie. Thanks so much for having me. I appreciate it. And yeah, I don't mention that Harvard MBA thing. It immediately makes me think here, I won't use those words.
I would never typically mention it in an intro. I just think it's awesome that you have a Harvard MBA and then you got into substance abuse. And that's the only that's the only reason I mentioned it.
No, I appreciate it. It was a great education. I learned a lot. They work you very hard there.
Awesome. Well, I want to talk a little bit. Daniel and I talk a ton about just our, I wouldn't say issues, but, well, I guess there are issues with residential inpatient treatment programs and just how a lot of the process is broken. And I think it's just so awesome, some of the stuff that you guys are doing. So I really want to get into some of the nuts and bolts on it. And I know you guys have come across some struggles and probably some naysayers saying that, you have to have, traditional brick and mortar, whether it's inpatient or outpatient, that, this model can't work in a virtual manner. And so I just really wanted to hear from you, when you guys got started, what made you really want to create kind of this new and innovative model that is completely virtual, without, a physical location?
Well, Carrie, I heard in your podcast from last summer about the struggles with your dad, and I'm very sorry for that.
Yeah, thanks.
We had a different version of struggles in my family, but pretty significant ones. My sister, who was a year younger than I am, struggled her whole life with opioids and alcohol, and she lost that battle back in 2010. And that was obviously a big deal. Right around the same time, my oldest daughter, who now has 13 years clean and sober, was in early sobriety, had a couple of years, and she was making it work. And so we saw it from both sides. We saw both the terrible things. Well, we saw plenty of terrible things with my daughter as well over the years. But it was a huge part it's been a huge part of my life since I was 25 years old and first persuaded my sister to go to rehab. This is back in 1984. Yeah. So I guess really, what we did was we married. I married the career that I had chosen with the one that picked me. And when we got started, we really had no idea if it would be a good idea. We were working. My one of the other co-founders and I were working on a clean energy business. So we had worked together at a solar power company, and my sister was back in rehab, and I was driving an hour and a half to go to family group each week, an hour and a half each way. And I just wondered, given that my co-founder and I had been working for months using only video conferencing to plan our next business, why it wasn't being used. My video conferencing wasn't being used in the treatment of addiction. And so I started asking around about it. I asked up at the treatment center and heard about it. And I found that with the exception of the federal government, nobody was really paying attention. There had been one significant effort, but it had failed. And so we just started pushing on it. And then when my sister passed away, that added a little bit more urgency to it. And we found that we were getting traction. We had no idea, would it work? Could we make it secure enough? Would it be legal? Would anybody want to work with us? All of those questions. So unlike a traditional startup where you really know what the market opportunity is and you go for it, we sort of went out after, an idea to see if it would work. And it has, which is fantastic. You asked me a bunch of questions in a row. So I also have a lot of experience with residential treatment as a buyer of services for my loved ones. The struggle with residential is that it's really effective to pull someone out of the situation they're in and treat them away from everything and really get them to focus on it. And it actually makes it quite difficult to relapse unless you leave. The problem comes when you get home. And of course, a good residential program will say, well, no, of course we know that. And you step down to an outpatient level of care, and perhaps you live in sober living for a while. And that happens, plenty of the time. But the struggle is that by itself, residential care really isn't the solution. And again, they would say that's true. And you may be aware of the recovery-oriented systems of care model that was adopted by ASAM, the American Society of Addiction Medicine, and SAMHSA, the federal agency that oversees that kind of thing. And it basically is all about lower levels of care for longer periods of time at lower cost. Because there's research that shows that the longer you're in treatment, the better the outcomes are.
Yep.
So
how did you guys have paved a way, and, just like, any kind of entrepreneur looked at a process that, how to make it better and, how to, really impact and change lives. Right. And that's what, humans helping humans is all about. And
sure.
we go down that mantra, but how did, having a virtual model that doesn't have kind of brick and mortar, I'm sure, and I know you wrote something on LinkedIn on it a while back, but how have you handled just the, kind of the naysayers in the field saying that, virtual outpatient can't work? I mean, I 150% think that's the wave of the future. And, obviously we're in that business and we're all behind it. But how do you handle, I'm sure you run into these folks and, get a lot of people that, think you're, green, have two green heads. So
yeah, exactly. Well, I used to say that people, either consider us voodoo or a tornado.
Right.
They either tell us that we're, it can't work. And you're right. I wrote something on LinkedIn about that. Or they see us as a tornado coming to destroy their jobs and their careers.
Right.
Neither of which are true. So let me go back first. There are studies that have been around for a while that indicate that doing the work online is actually as effective and sometimes more effective than in person. And I'll come back to why that might be. But the Department of Veterans Affairs measured outcomes of nearly 100,000 veterans using telemental health services, as they called it, between 2006 and 2010. And the studies I posted on our website, and they found that the results were as good or better than being in the same room. Also, there's a Reuters reported, on a study, and this came out in 2016, that as far as PTSD goes, that veterans, again, reacted just as well to sessions that were conducted online. So no one really needs to take our word for it.
Right.
The data are out there, and we of course, getting started as we did, we're very concerned about making sure that it was useful. So initially we thought we would be the perfect aftercare solution for residential treatment centers, but they have their own problems, and they have their own struggles with the insurance companies. And they were largely the naysayers that you mentioned, although a few were not. And so what we discovered is that people were finding us online. And what we knew anecdotally for years, and then were able to do a survey with a large enough pool to get statistically significant answers about a year ago, is that, the survey showed that just under half of our clients said that they were unlikely or very unlikely to use brick and mortar treatment to get help in a traditional setting. Another nearly 20% said they weren't sure if they would. And a lot of the rest, because we looked it up afterwards, had actually come to us from residential treatment. So one of the things that happens in our field is we look at the 10, 11% of the people who struggle with substance use disorders who get counseling and have some sort of professional treatment, and then we wonder why we're not reaching the other 90%.
Mm-hmm.
And we didn't go out after that. That was not our goal. But it turns out that the answer for at least part of that 90%, we don't know how much yet, is that the setting was wrong for them. And I think it comes down to the idea that you can just drop everything that's going on in your life and leave for a month or two or three. And what that's done, what that requirement has done, is it selects for people whose substance use disorder has progressed to a very critical stage.
Right. They're rock bottom. They're not working. They're, they can just stop everything in their life because
everything's stopped anyway.
Everything's gone, right?
But our clients, 85% of our clients have a job. And our average client is a 41-year-old working mother in a small town or suburb. And she's come to us for privacy.
Yep.
Because the stigma / shame is overwhelming, and she doesn't want people to know. And she can't believe she has a problem because she has a job and she has kids and she gets them to school and she, has a life. And she, in her mind, you can't be an alcoholic. And about 75% of our clients have primary diagnosis of alcohol use disorder. We'll come back. We'll come back to opioids in a minute. But she can't believe, she pictures an alcoholic, quote unquote, as somebody, as an old guy with a beard who lives under a bridge.
Right.
And that can't be her. So we've been able to reach a segment of the market that others are not reaching. And I think that is, so far at least, our biggest contribution.
Yeah, that's awesome.
The one thing that you said really stuck out to me. The longer someone is in treatment, the better the outcome is. And then talking about the typical patient, and I think we all know people in our lives who fit right exactly into the demographic that you serve most. So I want to ask this question. So why is your model more attractive than going away to a traditional residential treatment program with today's modern lifestyle? You mentioned, the privacy, the jobs, and the kids. What other kind of benefits does your model offer that the traditional model might not?
Yeah, walk us through kind of how the schedule works. I know you can work around work and things like that. Like, how does that work?
Well, so our female clients typically come to us for privacy as the number one benefit. Our male clients, we're guys, It's the cat's out of the bag, typically more with our male clients. So it's not so much privacy as it is flexibility. So we work with a lot of salespeople who travel a lot, truck drivers, people who work weird hours, night shift on, off. We've worked with people who worked on oil rigs, that kind of thing. And we work with also a lot of professionals who, again, that goes back more to the privacy, but also the flexible schedules. So we run 10 different schedules a week. So there are 10 different tracks you can be on, whether that's, Monday, Tuesday, Thursday, Tuesday, Wednesday, Friday, Saturday, whatever it may be. So that's the flexibility aspect of it. There are certain parts of what we do that are no different than what you might get in a brick and mortar facility. And that's for some really good reasons, which is that we follow the best practices protocols, and insurance companies are only willing to pay for those kinds of things. So we're accredited by the Joint Commission. We are licensed in states where we operate. And so there are requirements that go along with those things. And our counselors are all, veterans of traditional settings. Our clinical director has 20 years experience. She ran treatment programs for Kaiser Permanente in Northern California for decades. So there are parts of what we do that are really no different. Again, we work at the best practices, but we've had to learn, as far as benefits to clients go, what we think for them is best is that they feel more confident, more comfortable because they're at home.
Yeah.
What our counselors early on told us, and this was, back before we could had enough clients to do surveys that mattered, was that typically their biggest struggle is getting people to open up. But that online, what they were finding was it was getting people to stop talking because they were finally able to unburden themselves. Over 60% of our clients told us that we were their first professional psychology treatment ever.
Wow.
First counseling.
That's large.
So, I think that is the, from the perspective of the clinical benefit, that's probably number one is that it's a better setting for them.
Yeah.
In addition to the privacy and the flexibility.
Yeah.
Which are more logistical things.
Well, and I think that a lot of people who end up in the traditional brick and mortar treatment facilities, they start their search online, and obviously that's what makes you guys very unique is that they can continue their journey online right from the start.
Absolutely.
Through the chat
Absolutely.
processes. Sorry, go ahead.
No, please.
So along that same line, with the admissions process, the country right now, especially in rural areas, is having a lot of issues with mental health, with people not having access to mental health facilities. Their travel might be so far away, that sort of thing. So how does your virtual admissions process work today? And how do you think that can address the rural community shortage of mental health?
Right. Well, so a very significant, so our people find us online. We advertise, we work on, search engine optimization. People find us online typically. And what we hope is that they will connect in a live conversation. They typically don't want to start in video, interestingly. So they typically are happier either with a live chat or with a phone call. Mm-hmm. And a significant number of them do come from rural areas, and a significant percentage of our clients come from rural areas. The struggle, unfortunately, is that many people in parts of the country where many people in rural areas are using Medicaid, Medicare as their insurance. And, do not have a lot of cash available. And while our treatments, our programs are very inexpensive in terms of cash pay, it's still some money. And to that end, we offer free workshops, and we host mutual support group meetings, AA, NA, and others on our site. So because one of the things we don't want to do is turn people away. But the problem with Medicare is that it's still illegal, and will be until this summer, for us to bill Medicare for telehealth services that terminate at a client's home, at a patient's home. No one can do that yet, because early telemedicine was envisioned as being between professional offices, as beaming in a consulting physician, for example.
Yeah, home site is not a billable code, which is crazy since Medicaid.
Right.
And
so we run into that problem that basically there are people who their insurance will not cover us, and they do not have the cash to be able to cash pay, even though our prices are quite affordable. And so we try to help them with the free resources that we have, and also to find resources locally for them.
Got it. Yeah, no, that's a struggle with telehealth. Is it varies by state, it varies by insurance or Medicare, Medicaid, and it's just a complete debacle. So it's kind of crazy from that standpoint. I want to back up for a second and talk about, we did an infographic not too long ago on relapse rates, and I know you started to talk about it a little bit, but you referenced the veteran study and a couple others. What is the, inpatient versus outpatient? Are there any statistics that say that inpatient versus outpatient, a difference in relapse rates?
Well, relapse rates specifically, I can't quote them to you, but there's a very big study, which I haven't posted on our site actually, but I should, and I will, that shows that intensive outpatient is as effective as residential care for most people. And it was one of those studies of studies, so it was very large sample size.
Okay.
And what we hear from the health plans, from the payers, is that they like outpatient care better, and of course they like it because it's less expensive. But they find, and this is consistent with what we find, is that when you're in outpatient care, the things that you're facing on a daily basis can be worked on in your sessions.
Right.
So it's not, I went from residential care and now I'm back in the soup, and maybe if I'm just going to meetings, which is great, and we very much support that. But it's a different experience at meetings than if you are working through the problems that you are encountering in early recovery with professional treatment. And so that's one of the things that I think is of great value, and that the payers are beginning to look at it that way as well. They're beginning to look at residential care as more about medical stabilization, more about detox than about longer term care.
Yeah, absolutely. We talked about video telehealth, and we talked, video and mental health has been done for a while, obviously. What are you seeing as, you've got these patients coming in, they're signing up for an outpatient program that's done through, video, whether it's video group sessions or video, one-to-one counseling. What feedback are you getting from them on, adoption and them getting used to, being able to connect with a counselor that's, maybe in a different state or a different city? What feedback on, customer experience are you getting? Because, a lot of folks, might be using video every day in their real life. Some, it may be their first kind of interaction.
Absolutely.
They may not work for a company that does video conferencing. Or what kind of feedback are you seeing?
Sure, absolutely. Well, I think there's some amount of self-selection, right? Because as soon as you figure out that we're online and it's video, if you think that idea is not for you, you probably won't go forward with it. That said, in our survey from last year, 86% of our clients said they would recommend us, and 77% said that we were important to their recovery. Mm-hmm. And that 77%, I think, is I mean, I'm thrilled, of course, that 86% would recommend us. But the 77% are saying we're important to their recovery. And we all know a lot of things go into recovery. It's not just the treatment you provide. I mean, it's the long term. It's a recovery community. It's the support you get. So there are a lot of things that go into it. And as far as outcomes go, in the same study, 80% of our clients told us that they were abstinent at the time of the survey, and it was a broad range of clients. It was clients who'd been out for between 6 months and 5 years, and so the mean number of months was it was about 2 years, not quite 2 years. So 54% of them had been sober since discharge, and another 26% had a relapse and had recovered from that. And I guess that again goes back to that 77%, which is that the stuff that we had taught them, that they had discovered about themselves, and the structures that we had put in place together were useful to them in coming back from their relapse. And we know that, I mean, relapse is part of recovery. Right. Obviously, we prefer that no one ever relapses. It's dangerous, but it happens. And so that we've given them tools to manage that is very good. Clients who started in our IOP program, as opposed to lower level of care, 86% of them were abstinent at the time of the survey. So again, that's a more intensive program that's longer. Those clients typically stay with us longer. So we see that those outcomes are competitive, surely, with pretty much anyone out there.
Yeah.
We're going to do a bigger study this year. We're working with Yale Medical School, and so we'll have each year that goes by, we have a bigger sample, bigger pool of people to ask. We've also the 14% of people who didn't want to recommend us. We went back through there and we contacted a bunch of them, and one or two of them we screwed up, and others were, to be honest, I'm not trying to put it on them, but there were complications. Mm-hmm. But we followed up with all of them to make sure, and we ask our clients if they're interested to leave us feedback. We have an extension on our phone system, and some of them have left us some very nice messages, which are on our website under testimonials. And I would encourage anyone who's interested to listen, but they're very positive about the experience, and we work hard to make the experience great. There are a lot of small things that we've had to learn that people coming from traditional settings don't have to deal with. One of those is when you sign up for treatment at a brick and mortar facility, you're there, so you immediately meet with your counselor. They walk you back. If you're in residential care, you're going, back to your room. You're right there. With us, you sign up and you're home. Right. Nothing's changed. And so we've had to learn how to, there's a transition there from the admissions counselor with whom you've been working for however long that's been, and your substance use disorder counselor who's going to take you through the journey. So there, we had to figure out how to drug test, since by social convention we can't watch you pee in a cup. What do? Well, we discovered that there are oral swabs that we can use to do the testing, and there have been, we had to figure out, there's complexity there that we've had to work through. So every time that we find a place where we can make an improvement, we work hard to do that, and then we work hard to embed that into all of our systems and processes.
Well, that's awesome. we look forward to really watching your guys' journey and watching you expand and grow. And I know we're all fighting the same game with all the telehealth billable codes and insurance and Medicare and Medicaid. So I know we're all in the same camp on trying to get all that moved forward. So that's great.
Well, thanks so much for having me. I really appreciate that. And I respect the work you guys are doing. I think it's fantastic. And I wish you best of luck.
Well, thanks. We appreciate that. And if anyone has any questions for Peter or Lionrock Recovery, please let us know. Please click on the link to see what Lionrock is up to at lionrockrecovery.com and really see what they're doing, see some of the tools and we'll put some links to some of the studies that Peter mentioned on some of the information. Thanks for being on the show, Peter. We appreciate you being on the show and keep up to great work.
Thank you.
Thank you so much.
This podcast has come to a close. To hear more from the Executive Innovation Show podcast, subscribe, submit questions, and share the love. Follow us on social. We're everywhere.